Did you know that you're supposed to live 120 years? Yet most people in the U.S. die in their 60s, 70s, and 80s. Welcome to Longevity with Dr. Wilcox. For the next 60 minutes, we're going to add years to your life. The phone lines are open at 731-1230. That's 731-1230. Or toll free. 1-866-820-5528. That's 1-866-820-KLAV. Now let's bring on the host. Here is Dr. Simmon Wilcox.
Good morning. We're back. As always, we're trying to empower you with information that you can utilize and incorporate into your daily life to make decisions for yourself and those whom you love. We hope we're doing a fair job of that. We love to hear your feedback. We like the feedback we've heard so far. We always like the critiques. We thank those who last week kind of walked into the office impromptu. I think there was 2 or 3 people who came in impromptu and from the show and had inquiries and felt comfortable enough to come in even without an appointment to give us their opinion about how they experience our radio show. So I thank you all who came in. Today, before we get to the topic at hand, JR, our self-proclaimed voice of the people person here has an issue with me, issue with doctors. He keeps saying that I keep ignoring the white elephant in the room. But before we get to the big white elephant in the room, let me remind you that we have a weight loss offer to the public. We have personal trainers combined with IV therapy. Those packages run anywhere from $600 to $2,500 a month. It's good if you need to lose 20 or 30 pounds, but we really specialize in those people who need to lose 100 to 150 pounds, individuals who don't want to go through bypass gastric surgery. That we have an option on the table, combination of our IV treatments, as well as the personal trainer. And the deluxe packages actually offer myself as your personal trainer. But I usually only take those patients who need to lose at least 100 pounds or greater as part of my who I lend my personal attention to. Having said that, let's move to JR, our resident voice of the people, who says I've been ignoring the white elephant. I've suppressed his comment for most of our shows, but I told him today I'm going to allow him to speak out. And yeah, not that you don't speak the other days, but I'm allowing you actually to speak out and actually clarify your issue about the big elephant in the room, which I keep ignoring as I talk about longevity. JR, what was your concern?
Well, to retract a little bit for those who were not tuned in over the last week or so, my big complaint, and you folks can chime in with me if you feel that you're in the same boat as I am. When I wanted to go see my doctor, I had to wait, even though I had an appointment at 9 o'clock, and you get there at 9 o'clock, and they don't ever see you until 10:30, and then when they see you for maybe 3 to 5 minutes, and I have a great doctor. Before I met Dr. Wilcox, and he's been my friend and my doc for 20 years, and when I get in there to finally see him, Doc, how you doing? Oh, stamping out disease. And I said, I know, Doc, it's a grind in. And he goes, yeah. And, then what's your problem? What's going on, JR? Okay, my throat, this, that, whatever. By the time before I'm done talking, he's writing away on prescriptions. And it just frustrates me. Okay, come see me in 4 months so we can get a physical. You got to do your annual physical. Okay, Doc, see you later. I spent about 3 to 5 minutes with him, and I don't know if you all out there are with me or maybe have a better experience than I have. Let me know, but it doesn't seem to be the case, Doc, is it?
Well, the issue at hand, because I was one of those docs, is that when you're struck with insurance contracts that making you push through 30 and 40 people a day, it forces you to limit the amount of time a person has to tell their story. As a result of that, people like yourself walk out feeling shortchanged. But at the end of the day, the way the reimbursement is structured, there's a certain amount of volume you have to move if you're going to meet your overhead, and some doctors' overheads or maybe as low as $80,000 a year. Some doctors' overheads are as high as $300,000 a year just to break even, particularly when their malpractice insurances for some of those docs are $70, $80, $100,000. So in order to meet the financial grind, the system, unfortunately, is structured in a way that it needs to be redefined. I agree, but it's structured in a way, if you're in the insurance game, where the majority of your cash is coming from patients who are using insurance, then you're locked into moving volume. So, kind of in the defense of the doctors, as I always say, that's kind of the mode that we've been put in. Is not what we signed up for, but it's what we came into. Because we don't control the insurance part of the industry.
And I understand that too, and I'm not really trying to attack the docs, because I somewhat understand after talking with you several times as well about insurance companies putting the grind to these guys and penciling back all their costs and their fees and things of that nature. And I think the big boogeyman behind the deal is the insurance companies. Like you said, docs are just trying to survive, but in turn, we're still getting shortchanged, and I know they don't feel good about it. And it's been a pleasure, and I've been frustrated about it, and I think we've known each other for a long time, and I think that's why we've kind of came together, and to be somewhat, instead of, you can stand there and complain about it all day long, but if you want to help them do something about it, that's kind of how we designed this practice, is that we're going to give people individual attention. We're going to take care of their people. We're going to answer their questions. We're going to spend time with them. And one of the better things that I think, and it's my new saying, is if you want to stay healthy, don't get sick. Mm-hmm. So, be instead of being reactive, be proactive, and let's get in here and get yourself on a plan. And I know it's working for me. I mean, I'm plugging into everything that we're doing myself. I'm feeling better. I'm losing weight. I'm having more mental clarity. I have much more energy. I'm real passionate about what we're doing here, because it's nice to be able to do something about what you complain about instead of just sitting and complaining.
And we're proud of you, JR. You are losing weight.
Come on.
Your number of bowel movements a day have increased, and
yes, they have.
We're proud about that. So we're happy that you're walking the walking.
Come on.
And not just talking it.
That's right.
But you had another issue, and I'm looking at this little article in front of you. What is that article about, JR?
As we're scrolling through the internet, I picked this up from a website, and it says doctors are the third leading cause of death in the U.S. Sounds kind of crazy, don't it?
The big white elephant.
That's the big one.
The big white elephant. Doctors and that article, it was.
It's on Natrio Doc. It was made. It's not by some radical organization. I didn't make it up. It's from the Journal of American Medical Association, formerly JAMA, and they are the people that write about the medical association.
It's a legitimate medical magazine.
Yeah.
That has a lot of respect, and the doctor, Dr. Starfield, I believe her name is the one who actually wrote that. And it does talk about, it does identify doctors are the third leading cause of death behind cardiac disease and behind cancer. And that's, to me, that's discerning to think that I'm among the group that's in that category, because, my thing is longevity and getting you to be 120 years of age. And how can I do that when I'm in the group of people who are part of the third leading cause of death? And when they talked about that article, if you really drill through that article, it also tells you that the fourth leading cause of death is pharmaceutical companies. But when we looked at the data for the doctors, it talks about 80,000 infections in hospitals a year, 100,000 plus negative effect from drug errors. It talks about unnecessary surgery, 12,000 or so a year, medication errors, 7,000 or so. And so it's disheartening when you see the kinds of things that are happening to add up to that particular event. So we're trying, though, JR. We're trying to make a difference. Clearly, every doctor leaves medical school trying to be right 100% of the time.
Absolutely. I think to my taking hat off to the docs, I think that if they're going to be a doctor in today's world, or and I'm very I get excited when somebody says they want to be a doctor. I said, why do you want to be a doctor? And it's not because they don't think doctors make so much money or what have you. It's a lot of money that goes involved in the education. There's a lot of time, but I think they really have to have a heart to do it. It's not just about, I'm going to be a doctor because they make great money or things of that nature. I think it almost goes hand in hand with school teachers. School teachers, they don't get paid anything. They're the most underpaid, undervalued people that I know, and that I think, but they have to have a heart to try to make a difference inside some of our kids' lives. So I think it's changed a lot, especially with the boogeyman Obamacare coming. I don't know. Everybody's kind of in a little bit of spiral, not knowing what's going to happen.
Well, a couple of things. Let me speak to the money issue. The bulk of the money in medicine is not made by doctors. It's made by insurance companies. It's made by the pharmaceutical companies. It's made by the hospitals. It's made by the owners of the home health cares. It's made by the owners of the hospices. There are many plumbers and electricians who make more money than the doctors. So the doctors are probably 8th or 9th on the totem pole in terms of who's making the money in medicine, although at the end of the day, the system doesn't run without the doctors in the middle of the system. But the system is flawed. The system is broken. I can tell you, as an emergency room physician, when a patient comes in to the emergency room, they tell their story to the clerk, the intake clerk, who's really there to take their insurance information. Then they tell the story to an intake nurse. The story may not be as complete as the first time they told the story. Then they tell the story to the third person, who is the nurse who's going to be with them when they put into a particular cubicle. The story often the third time out is not as complete as it was the first time or the second time out.
Right.
Then fourth time comes along, here's the doctor. And by the time I arrive to the patient, I get half the story. Because the patient has assumed that if they've told the story 3 times, I know everything they've told the 3 people who preceded me. And they don't see a need to tell me, the doctor, the whole story. And that's the first part of the problem.
Gotcha.
Is that often we as doctors don't receive the whole story. And patients assume the system is structured in a way that that story will be passed on. I can tell you, you remember Sherry? She's the girl we made house call. We make house calls. I didn't want to say it. We do make house calls, but Jerry and JR goes with me. Sherry, she doesn't mind me telling the story. Sherry, who has lupus, she has colitis, she has Crohn's disease, has hypertension, and she has diabetes.
What about, she has fibromyalgia too?
Thank you, JR. She has fibromyalgia. You remember that?
I may not remembered all the others, but I do remember that.
Her car was broke down one day, and I wanted to treat her, and she needed treatment. We went to her house. On a Saturday, it was went to her house.
Yep.
And Sherry presents to the emergency room. First of all, the way the forms are made out, there's not enough room on the form to even document what she's articulating. And to really listen to her story, it would take my entire ER shift to hear her story, to even understand what's going on with her. When she first came to the office and presented her story, it took me 2.5 hours to hear the whole problem. And since she was in a 15-minute slot, I ended up having to see other patients in between her to finally get her through the process before I could begin to get my hands around what her problem was. So first of all, if you really got issues that are complicated, the system isn't structured for that. The paper we're given to write your complaint on doesn't have enough lines to absorb the information, unfortunately. Now, if you have a broken leg, then it's kind of cut and dry. If someone shot you in the belly, it's kind of cut and dry what I need to do. But if you're coming to the table with chronic diseases, which a lot of what we see in America happens to be, if you come to the table with chronic diseases, and those chronic diseases are now flaring up for whatever reason, the system isn't really structured in a way to allow you to get your story, your full story, on the table. And that's the beginning of the problem with the system. Patients can't tell the story. And so we often will abruptly get to the lowest line and grape what sounds like the problem and begin to treat that particular problem. Let me just share the rest of the story when we come back from break, but you're listening to KLAV 1230, KLAV 1230 AM, KLAV 1230 AM. Please feel free to call us at 702-731-1230, 702-731-1230, and we'll be right back.
Are you having difficulty detoxing from drugs or medication? Let Dr. Wilcox help you. Call at 702-749-7111. His revolutionary detoxing program is designed to help you detox without the discomfort of other procedures. Call him at 702-749-7111. Visit his office in Summerlin at 8751 Charleston, Suite 210 behind Fleming Steakhouse. Call Dr. Wilcox at 702-749-7111.
Do you know that 60% of the healthcare dollars spent over the next 10 years will be spent on stem cells or a stem cell related process? Listen in as we define for you how medicine will change your life and the life of those who you love over the next 10 to 15 years.
Covering the issues that matter and adding years to your life. Longevity with Dr. Wilcox. Monday and Thursday morning at 10. Only here on KLAV.
Hello, my name is Dr. Simmon Wilcox. I'm a board-certified physician in family medicine. I have 20 years' experience with drug and alcohol abuse and treatment thereof. I bring to you a new service at my facility. We're asking you to examine your household, your family, your community, and decide if there's someone there who needs what we have to offer.
Give Dr. Simmon Wilcox a call today at 702-749-7111.
Longevity with Dr. Wilcox continues. Here again, your host, Dr. Simmon Wilcox.
We're back. I just want to finish the story as I begin to share about one of my patients, Sherry. And let me say, Sherry, if you're listening, I did change your appointment from today to tomorrow. I hope the office calls you to tell you about that. That when you have that many medical problems, and she's typical of individuals who come in who have multiple medical problems. They're bringing a bag of 15 different medications, and there's not enough time necessarily to tell the story. That's the first part of the problem. And if you look at the statistics, 47% of all the doctors interviewed will tell you that they feel like they're burnt out. About 48% of all the nurses interviewed will tell you that they are burnt out because of the stresses of the job at hand. So that's the first part of the story, the problem. The second part is often if in an emergency room situation, in terms of mistakes that are being made, if 3 people come in the ER and all 3 have similar names, you cannot believe the amount of confusion that occurs, particularly when different doctors are taking care of those individuals, and each doctor writes a set of orders. Those orders go to wherever, to the lab, to x-ray, etc. And the x-ray techs now have to make sure, particularly if no one has identified the problem, what often happens, the x-ray techs will come, or the laboratory techs will come to draw blood based on a certain order, and often the blood is drawn on the wrong person. The x-ray tech are taking x-rays on the wrong person because the names are so close and no one has highlighted the fact that you have 3 people in the ER with similar first and last names. That is a disaster waiting to happen. It's just a luck of the draw that all 3 people with similar last names and first names happen to show up at the same time. If one doctor's taking care of all 3, then it's easier to work through. But you have 3 different healthcare professionals taking care of them, and orders are going out. Individuals come to the table. You come in assuming there's only one person in the room with this particular name, and you go to the first one, and it may not be the correct one you're going to. So it's a major setup for error in that particular situation. Superimposed on that, medications often have similar names and similar abbreviations. And so they've tried to, in many circumstances, actually disallow certain abbreviations to try to decrease the confusion in terms of what is going on and what medicine is attempted to be delivered. So it's a collective problem, and at the end of the day, the burden falls on the doctor, who may not even be involved in the process where the mistake actually occurred, but at the end of the day, we're the captain of the ship. So the accountability falls on us. One of the areas of infections that occur is something as simple as the Foley catheter. I believe it was a couple of years ago when the hospital, Johns Hopkins, was saying that the number of Foley catheter infections and deaths related to it was approaching the same number of individuals who was dying in the hospital for heart attacks.
Wow.
And it's a $12 item, you know. and so what they've done, they set up a protocol. And the protocol they set up has reduced the number of infections to almost zero from the Foley catheter. But it takes a collective effort to agree to a protocol in terms of how you insert the Foley catheters, how you micromanage the Foley catheters, and how often you change the Foley catheters. But you get an elderly individual who's already fragile, who's already on the border, and they come in with complaint of belly pain or chest pain, and now because they're recurrent urinations, the Foley catheter is placed in, and often the nurses say, "Doc, Mrs. Jones has urinated 5 times. I've been in the room 5 times. She's taken up all of my time changing the bed sheets. Can I put a Foley catheter in?" You say, "Yeah, okay, put a Foley catheter in." But when you're putting the Foley catheter in for almost a social reason, but politically, I say yes, okay, you can put that Foley catheter in. We have to have a system in place that micromanages that Foley catheter, because that Foley catheter is probably the number one cause of infections we see across hospitals, because it leads to a urinary tract infection. That urinary tract infection leaves the urine, leaves the bladder, and goes into the bloodstream. It becomes what we call a systemic infection throughout the body. And if you're already on the border with a heart issue, if you're already on the border with a diabetic issue, with a lung issue, it will push you right over and will be a cause of death. So yes, the doctor's accountable because the doctor ordered the Foley catheter. But it means that we have to have the system adjusted in a way that we have a process in place to reduce the number of infections that occur from things as simple as a $12 Foley catheter, particularly when you came to the hospital for something else.
Right.
And now you have this new, as JR like to say, boogeyman, the new boogeyman,
A new disease,
that you didn't sign up for, and part of the problem with the system is that the sicker you get, the more money I get paid. And so it's not that I want.
Not that you want. I know that. I will say that. I'll step in there and jump in for the people, and go for the docs this time. I don't think their intent is to make you leave worse off than when you came, or to add on to your issues at all.
Exactly. And the system is designed wrong. The sicker you are, the more money I make. Even if your sickness is because I made an error, I get paid more fixing the error. I should be somehow punished or compromised, docked or something, but not paid more money because I'm fixing something that I indirectly created, even if it was the Foley catheter. I need to be made more accountable in terms of what is transpiring, but that's not how the system is structured. The system is structured that the sicker you are, the more money I make. And I've always said that payment follows format. I mean, medical practice follows the format of payment, and we have to restructure how people are being paid, that are redefine how practice is being activated. In the United States, we've said this earlier, I think on our first show, we spend more money per capita than any other country in the world. Yet we are still ranked as number 15 when it comes to quality of healthcare that we receive. We look at Japan. Japan spends 60% less money, has the same level of technology that we have, and does not have the degree of complications or medical errors that occur. Part of the difference in Japan, they use all the technology to make the diagnosis, but they've accepted the attitude that we don't have to treat you just because we diagnosed you. So that every diagnosis does not necessarily have to have a treatment. Often they just give care meaning love for family members, etc. They don't necessarily put you in the hospital for the things that we admit you for here in the United States. So it's a different approach to healthcare than we have here in the United States. But we spend 60% more than many of the other countries, and yet the quality of healthcare in Japan and places in Portugal, in Jordan, and other places, their quality of health and life expectancy is much higher. Some of us say, well, some of those numbers are altered because of the number of individuals who are living in ghettos and those who are financially underserved, etc. But even when you remove, particularly one study removed everyone in the study who happened to be black, who were living in low income areas, they removed them totally from the statistics. And it turns out that still the death rate, even the infant mortality rate, was still higher in the United States than it is in some of the other undeveloped countries. So there are things that still needs to be done.
You know, what's sad about the inner city and things of that nature, Doc, as I'm just seeing this, is that that a lot of those folks can't afford health care, nor they go to the doctor when they should, or maybe could, and they have a hard time even getting there. So that would probably eliminate them from an equation as well.
Well, yeah, because the numbers we're looking at are really based on people who were admitted to the hospital. Yeah. We haven't even gotten to look at how many people die because they don't have access or never really made it to the hospital for care. As we see and as we know, even in the recall about a year ago, all those items that was on the shelves in the pharmacies, all those items that contain the phenylpropanolamine, the Actrim for the Diagam, the Alka-Seltzer Plus for children's cold, the Alka-Seltzer Plus for cold and flu, the Dimetab, the Dexatrim, all those items, the triminic syrup, was said to cause seizures and brain bleeds. These are items you buy over the counter without a doctor's prescription. So a part of the problem in the United States happen to be pharmaceutical. And these are pharmaceutical items that you have access to without the doctor's intervention. But these are names that I've grown up with. I'm 57. Yeah. I've grown up with Alka-Seltzer.
Remember Dimetab? Earache. I had an earache. My mom gave me a scoop of a teaspoon of Dimetab.
Quercetin.
Even tasted good.
12 hours. Yeah, I like it. Give me some more of that. So these are names that we're used to. That it doesn't require a physician prescription, but we found that we're causing strokes and seizures in children. So that there was a recall a year or so ago. But so there's items in our healthcare system that really needs to be.
Let me ask you
addressed.
something, Doc. These pharmaceutical companies are pretty smart guys, aren't they? I mean, they really are. I mean, they're intelligent. I mean, they come out with a medication and they sell it over the counter. Don't they? Don't they know they may have a few side effects?
Well,
I'm setting you up.
I know you're setting me up because we had this conversation at dinner one night. Thank you for setting me up, Gio. One of the.
We're not sponsored by any pharmaceutical companies,
obviously. And we won't be.
And we never will be.
The issue is that the pharmaceutical companies actually calculate what I call a kill rate. They calculate the amount of side effects, potential deaths from the side effects of a particular drug.